you. Good morning, everyone. Welcome to an exciting neuro-ophthalmology talk this morning. We have a sensational topic today, caring for two neuro-ophthalmological disorders in pregnancy. Our speaker today is Dr. Kathleen Diggory, who is a globally renowned and a respected figure in the field of neuro-ophthalmology. Dealing with a pregnant patient is not straightforward always. There are a lot of challenges. You have to deal with not one, two lives. Plus, there are a lot of other challenges such as, trouble with investigations. There are a lot of restrictions there. The treatment that we commonly offer may have some teratogenic side effects, so we've got to be very careful there. Plus, the biggest problem is most of these patients are very anxious, and the family are also very anxious to deal with that, and treat these patients is a big headache for any treating doctor. So Dr. Diggory is a distinguished professor of neurology, professor of ophthalmology, and adjunct professor of OBGYN at the University of Utah School of Medicine. After receiving her BA in English and German from Augustana College in South Dakota, she completed a master's degree in English literature at the University of Arkansas. She then completed medical school at University of Iowa, followed by an internal medicine internship, a neurology residency training, and a neuro-ophthalmology fellowship at the University of Iowa. She then joined the University of Utah in 1987 and directed the neuro-ophthalmology program at the Moran Eye Center. She established the University of Utah Headache Clinic. Dr. Diggory is a former president of the prestigious North American Neuro-Ophthalmology Society and the American Headache Society. She served as a secretary at the American Neurological Association. She sits on the editorial board for the Journal of Neuro-Ophthalmology, and she directs the Center of Excellence in Women's Health at the University of Utah. Her clinical research focuses on disorders of the eye and migraine, intracranial hypertension, anterior ischemic optic neuropathy, photophobia, eye pain, and neuro-ophthalmic disorders in pregnancy. She has authored over 300 peer-reviewed articles. She recently co-authored a book titled Case-Based Guide to Eye Pain. She has received numerous awards in the past. I can't list all of them. So to list a few, in 2004, she received the Gender Equity Award. Since 1994, she has been listed in the Best Doctors in America. In 2008, she received the Distinguished Service Award from the North American Neuro-Ophthalmology Society. The same year, she also received the Linda K. Amos Distinguished Service to Women Award from the University of Utah. In 2012, she received the Martha Hughes Cannon Award, recognizing her efforts in women's health for the state of Utah. In 2012, she received the Rosenblatt Award from the University of Utah. This is the highest university honor. In 2014, the University of Zurich honored her as the first Heidi Fritti-Nigli guest professor, where she worked to promote women faculty in medical school. In 2008, she received an honorary doctorate from the University of Zurich and also named Distinguished Professor of Neurology at the University of Utah. In 2019, she received a Lifetime Achievement in Headache Medicine Award from the Headache Cooperative of New England. She received Distinguished Alumna Award from the University of Iowa in 2019 and also from Augustana University in 2023. In 2021, she ranked among the top 100 women in ophthalmology with Ophthalmologist Power List. Most recently, in 2024, she received the Solomon Lecture Award. Dr. Diggory is married with 2 adult daughters. Her hobbies include reading and discussing books, running, cross-country skiing, fishing, opera, hiking, and traveling. Please join me in welcoming our distinguished visiting professor, Dr. Kathleen Diggory.
It's entirely too much. Well, first of all, I just want to thank everybody for inviting me. I'm very honored to be here in Ontario. I told Arun I was in Ontario on the western part in the Quetico National Park just a week ago, canoeing and paddling and portaging. So I have nothing to disclose or have financial interest in this talk, but I do have to disclose a couple things, if I can get the slide to advance. Want to go? So the first is I'm married to a high-risk obstetrician. that sparked my interest in women's health disorders and also in neuro-ophthalmic changes in pregnancy. And I've also been pregnant twice myself and have two daughters, Johanna and Gita. And so with that, I'm going to embark on talking about neuro-ophthalmic changes in pregnancy, because I want at the end of this lecture for you to think about pregnancy as kind of a window to women's health and kind of a window to the future of women's health. And there's an important piece of this for ophthalmologists. We're going to talk about the normal changes in the brain and eye in pregnancy, and then we're going to run through some cases of neuro-ophthalmic conditions. And in each part of this talk, I want to stress how these common neuro-ophthalmic problems can affect the future health of women as well. So it's really clear to obstetricians, and now it's becoming more clear to everybody, that pregnancy is actually, you have to take your family history into account and the genetic piece of this and everything. But the women's health during pregnancy actually predicts some of the future health of that individual and even of their offspring. So I call pregnancy a stress test for health. And because there's major cardiovascular changes, immunologic changes, and even coagulation changes that occur. Whoops. So the first change is that there is a change in blood volume. So in pregnancy, and this is all just normal pregnancy, 30 to 50% of your blood volume is increased. Also, cardiac output is increased by almost the same amount and further increased during labor. And then coagulation factors make pregnancy somewhat of a hypercoagulable state, which becomes kind of an important piece when we talk about stroke and vascular complications, because there's increases in plasminogen, fibrinogen, many of the blood clotting factors, and decreases in fibrinolytic activity. In addition, there's hyperplasia of the smooth muscles, fragmentation of reticular fibers within blood vessels, and of course there's muscular changes. If any of you have been pregnant, you know that there's changes that occur in your ability to retain fluid. By the end of pregnancy, you've got at least 2 liters of extra fluid in your system. So, I mean, it's kind of this dynamic state, and that's why it's really a stress test for health. Okay, so there are some immunologic changes that also happen, and as many of us know who take care of people with optic neuritis and multiple sclerosis, pregnancy is a time of almost improvement in the immune system. There are no changes in immunoglobulins, but there is changes and decreases in cellular immunity. And then after the pregnancy is over is when you're at the greatest risk for having a recurrence of some type of inflammatory condition like uveitis or MS. Now, there's a whole bunch of physiologic changes that occur in the eye. The first and very common one is refractive changes. And these seem to be mediated, at least in part, by the change in fluids in the lens and also the cornea. And so there often is an induction of myopia. So people who are pregnant may come to you and say, you know, something's wrong with my vision. I need new glasses. And that will change again. There's a fall in the intraocular pressure in the second half of pregnancy. And one of the most difficult things for a lot of pregnant women is dry eyes. About 80% by the 3rd trimester will have complaints of dry eye symptoms. And many people become contact lens averse because of this changes in the dry eye, but also the corneal changes that occur. Even in the retina, there can be some microscopic changes and a slight increase in vascular density in the macula. We don't know of any changes in the optic nerve, although some people have reported in looking at OCTAs, changes in perfusion. Doesn't want to go. I'm not sure if this thing is working. So one important thing for ophthalmologists to recognize is that a diabetic retinopathy can worsen during pregnancy. And it often depends on the hypertension and also on diabetic control. The other thing that I think is really important for ophthalmologists to at least be aware of is if you get a woman with a history of gestational diabetes, you have that person has a higher risk of developing diabetes in the future. So it's important to at least ask that question in clinic. And by 5 years, about 5 times a relative risk for developing diabetes and even metabolic syndrome within the next 20 years. So having that gestational diabetes is actually an important risk factor to be asking about. So many of us have patients that come into us looking like this. This was a young woman that came into us. She had these anomalous appearing discs, and you can kind of see how they're sort of cupless. They look kind of weird and anomalous. And one of the problems that this is a topless disc. And this is related to the fact that her mother actually had diabetes in pregnancy. And it's one of the things you want to ask about, did your mother have, and she has this visual field defect. She got sent to us with this visual field defect. She was completely asymptomatic because she'd been living with this her whole life. But the question we asked her was, did your mother have diabetes? And the answer was yes. So it's an important thing for people to realize that that actually can happen. Now, there's some pretty interesting brain things that can happen as well. The brain does decrease in size. Now, there was an article in August Nature showing fMRI changes in the brain of women who are pregnant by the 3rd trimester. And this is, we think, related to changes in hormonal changes, but also alkalosis. And these changes are there to try to get a woman's brain ready for taking care of an infant. If you would have told me when I had a baby that I was going to get up in the middle of the night and be happy about it and just keep on going for the next day, I would have said you're crazy. But that's what happened to my brain. I just get up in the middle of the night and it would be just fine. So these changes that are going on are now just beginning to be studied with functional MRI. Another thing to be aware of is that the pituitary can increase in size. In fact, if you look at an MRI scan on a woman who is pregnant, the pituitary gland can almost look like there's a microadenoma because it's almost more of a convex appearance in pregnancy. Postpartum, it does return to normal, whether the woman is nursing or not. And rarely there have been visual field changes associated with this change in the pituitary size. Sleep drastically changes in all trimesters, and this also can be associated with the development of preeclampsia. So it's an important question to ask a pregnant woman about sleep. Now, you may ask yourself, well, what tests can I do? Like, we all are nervous when we take care of somebody who is pregnant because we are taking care of the mother, but we're also taking care of the baby. And one of the messages that I have for everybody is the most important thing is to do the right test to come up with the right diagnosis, because if you take care of the mother, she will take care of the baby. So there are many neurologic things that we do, MRI scans. We try to avoid gadolinium in pregnancy. If we're going to do CT scan or angiograms, we do use abdominal shielding. There's no contraindication to ultrasound, EEG, lumbar punctures, OCT. Fluorescein does cross the placenta and it can be found in breast milk. Some people recommend dumping if the woman is breastfeeding. ICGs are fine. It does not cross the placenta. And of course, if you want to do punctal occlusion for dilating drops or glaucoma drops or whatever, you can do so. But in general, make the diagnosis for the woman because that's the most important thing in any neuro-ophthalmic condition. So I'm going to be talking about vascular problems. I'm going to mention migraine and aura. I'm going to also go through some pregnancy-specific conditions, and then we'll talk a little bit about some things that come up with delivery. So this is a 28-year-old woman. She's 28 weeks pregnant, and she has the sudden loss of vision in her right eye. No previous stroke, no family history. So she comes into ophthalmology where she has you can see that she is occluded her retinal artery here, a branch retinal artery, which is given her this field on the octopus. She gets a workup, and remember in these days when people have like an amaurotic episode or monocular blindness, we look at the brain as well because they're at increased risk for stroke as well. She had a normal echocardiogram, but a transesophageal echocardiogram, which was done during pregnancy, showed a patent foramen ovale. So a host of coagulation studies were done looking for why she could be hypercoagulable. And yeah, I don't know what's going on with this clicker here, but you want to click it? Oh, sorry. And I just want to remind everybody that you can make the diagnosis using OCT of a branch retinal artery occlusion also. This was another case that occurred in pregnancy. So what we did was recognize that she did have this. We did put her on a low dose aspirin, which is safe in pregnancy. Stroke in pregnancy has a variable occurrence between 9 and 34 per 100,000 deliveries. And the hemorrhagic strokes are most often the ones that can be deadly. And pregnancy by itself, because it's kind of a hypercoagulable state, can increase the risk of having a stroke or an event even in the eye. And some countries have a marked increase in stroke risk, especially where there's no prenatal care. But the most important thing is to come up with the diagnosis and treat her. She did not undergo a closure of that patent foramen ovale. It was thought to be not big enough to close. So stroke in pregnancy, the most common is embolic, usually from the heart, but there's many other different causes. I highlighted drug abuse because we're in Utah, and you think of all these clean living people in Utah, but even we have cocaine, ephedrine, methamphetamine use, and you have to ask about that whenever you've got somebody with a retinal artery occlusion or a branch retinal artery occlusion. Arteritis also can occur in pregnancy, and then rare causes, migraine, especially with aura or Susac syndrome. If people have hematologic disorders, these are often manifest during pregnancy, so it's really important if a woman has one of these underlying factors that those be determined. And the heart in a pregnant woman can be a source of emboli because peripartum cardiomyopathy is not rare, and you can have variations of that same theme. Even rheumatic heart disease can reoccur in pregnancy, and you can have this paradoxical embolism. That's why we were looking so carefully for a cause of venous thrombosis with her patent foramen ovale. But this is a message you're going to hear. The best outcome for the baby is taking care of the mother, getting the workup, knowing what caused the stroke so that you can prevent anything future from happening.
No, hang on, I'll do it.
Okay, thank you. So here you can see all the different retinal disorders that can occur in pregnancy. Central serous chorioretinopathy is probably one of the most common, along with the hypertensive retinopathy, and we'll talk a little bit more about that. But I want you to see that retinal artery occlusion is on this list. But there's a whole host of things that can occur in pregnancy that you have to be aware of. But retinal artery occlusion is one of them that you have to take seriously. So does stroke in pregnancy increase the risk of stroke later on? And in general, data would suggest that there's no age increase with age unless there's a comorbid disease. So if you have Leiden factor 5 or you have some other hematologic abnormality, yes. Now, if you have antiphospholipid antibody syndrome, and you really have to look for this, that is a risk for recurrent stroke and of course, a risk for preeclampsia. We're going to talk about what that looks like as well. And if somebody does have thrombophilia, you do have to do preventive therapy, usually heparinoids and not Coumadin because of the risk of birth defects with Coumadin.
Do it.
Yeah.
Just let me know next slide.
Can you advance that one?
Yeah.
Okay. All right, I'm going to change gears. This is a woman who is 31. She's had 3 pregnancies, 1 delivery, and she's currently 13 weeks. She's had severe nausea and vomiting, and she felt a pop behind her right eye with a droopy lid and minimal pain, and her exam really was normal except for a little bit of proptosis. One of the residents want to say what you think happened here.
Maybe you can get one of our senior residents to chime in on this.
What was the size of the pupil?
But
What was the size of the pupil at
the pupils were fine. The pupils were normal. She did not have a third nerve palsy or anything like that, but she did have proptosis. Well, this is so how about from this imaging? Can you tell what's going on? On the left is an MRI scan. And you can see this kind of mass here. And on ultrasound, there was a little bit of a mass there. And this was a spontaneous orbital hemorrhage. And there's 2 times when these can occur. And ophthalmologists need to know about this because think about it, you get called to the room, big pop, you're going, oh my gosh, is this an aneurysm? What's going on? But everything's fine, okay? No third nerve palsy, no ptosis, no nothing else except a little bit of a proptosis. But there's 2 times when this happens. The first is in the first trimester with nausea and vomiting, especially people who have hyperemesis gravidarum, which is not rare in pregnancy. And the second time, and I've seen it in both situations, is with a Valsalva maneuver in the second stage of labor when women are pushing and they can have this happen. The symptoms are usually a sudden double vision, a little bit of proptosis and pain. You can make the diagnosis with MR, CT, or ultrasound. Sometimes people can have a varix, and of course the dreaded complication is could they have had an aneurysm rupture? But usually you're going to see other signs of a third nerve palsy. There's usually no treatment. This spontaneously resolves and it's not associated with recurrence. But it's pretty dramatic and pretty scary when you see it. Okay, next patient that we're going to take care of here is a 24-year-old woman. She's 30 weeks. She's got increasing headaches. She's had dim outs of vision. Her neuro exam is normal. Her blood pressure is normal. She's been to the emergency room 3 times. I don't know if this happens in your situation, but I get this call and I know what this is. What exam did they fail to do? They failed to look at the back of her eye, right? The fundus exam. And she had bilateral papilledema. And so what do you have to do? You have to figure out what's causing the papilledema, right? And so in this situation, on this woman, you want to advance that?
Sure.
You've got to think about mass lesion, of course, which can present as papilledema, and then other causes of increased pressure, idiopathic intracranial hypertension, and then cerebral venous sinus thrombosis, okay? Because remember, I told you that pregnancy is a hypercoagulable state. And of course, eclampsia, but her blood pressure was normal, and meningitis. And on her imaging, you can see on her MR, she had an empty delta side. Normally, the sagittal sinus should not have anything in it, it's blood. But here is like a little mass-like lesion right there. And then on an MRV, you can see she's lost part of her sagittal sinus. She's lost her entire transverse sinus there on the left side. So she had cerebral venous sinus thrombosis.
Next.
And
Nope.
well, so this has been recognized as a complication of pregnancy for many, many, many years. Remember, it's related to those clotting factors that are abnormal. And the most common symptom is headache, 74 to 75%. And many of these get just brushed off as migraine, right? Going to the ER, thinking it's migraine. Third can have seizures, hemiplegia can occur, but thinking about looking for papilledema. I don't know about your system. I would love to have a camera in our emergency room to take pictures on all these people that come in with headache, because I think that we do a better job of picking up on things like this before it gets out of control. There are many, many different causes of thromboses. As you know, the one we look for a lot is the Leiden factor 5, because that it gives you about an 8 times risk factor of having a venous sinus thrombosis. But there are many other causes that you have to think about as well. And most of the time, the neurologists help you with this. You know, the underlying cause for this person, we did look for antiphospholipid antibody, protein CNS, Leiden factor 5, and generally there's low recurrence in this. It's not like you're going to have recurrence unless you've got one of these coagulation factors, and then for future pregnancies, you do need to be on a preventative. All right, now this is another woman, 34-year-old, 12 weeks gestation, and she has disc swelling and headache. She's had recent weight gain. She's now obese. She's been rather healthy up till now, and some transient dim outs of her vision, whooshing noises in her head, and more headaches than her normal headache. She has underlying migraine, but her headaches have increased, and she's got bilateral papilledema. She's got big blind spots on her visual fields with some early arcuate defects, and her MR, and here MRV is also normal. You've got to, in pregnancy, for sure, anybody coming in, you have to look for venous sinus thrombosis in all people with what you suspect is idiopathic intracranial hypertension. Her lumbar puncture shows an increase in her opening pressure up to 320, and her fluid studies are normal. So IIH, I don't know, we see a lot of IIH because we have obesity in Utah. I don't know about Ontario. Maybe you guys are all skinny and healthy and, and out running and everything. But remember, this is as common as multiple sclerosis in obese women. The average age of onset is between 14 and 60. So it's kind of during those childbearing years. And of course, women are more prone to this. We don't have a genetic or gene identified, although there are a lot of case reports in families. So what about IIH in pregnancy? The first thing is make the right diagnosis and go all the way to make it. Get the MR, get the MRV. You can do it as time of flight with a lumbar puncture. There are some people who think you don't need to do a lumbar puncture anymore, but you know what, you do, because you got to know that there's normal protein, normal glucose cells. You follow the woman as if she's not pregnant. That means you get visual fields frequently. Now, this woman already had field defects, so she's at high risk for visual loss. one of the things I'm sure you're gonna get asked, because I get asked this. The OB, of course, is kind of in a twit because they're going, oh my gosh, she's got increased intracranial pressure. Should I deliver her by cesarean section? What should I do? And the studies are pretty clear here that just follow normal practices of obstetrics. You could do spinal anesthesia. And I put down team sport because I think that is really an important point. And that actually was made by one of you guys in Toronto that, you know, when you see somebody with IH, you've really got to work closely with your high risk, right, provider and there's no greater risk of pregnancy, except recently there have been some studies that have shown that there might be more preterm births. There may be more prone to hypertension. So many of us don't do blood pressures in the office, but in pregnant women, get a blood pressure. Just make sure that you do that because that ends up being a really important piece. And there's a couple reports about congenital anomalies being increased in women who are pregnant, not because they're on acetazolamide, but just because of this disorder. I think we need more data here. We try to limit weight gain. You have to gain some weight in pregnancy, but you try to limit excessive weight gain. Medications, chlorothalidone is actually a B drug. Remember the FDA has a classification of A means you can take it. Well, there's nothing that's A. Caffeine isn't even A, it's like a B. Do you know what I mean? It's just like, but so no drug is an A, but B is sort of pretty safe. C means use it if you need to. D means don't use it unless you absolutely are against the wall. And X means don't use it ever. And they've gone away from that classification, but it's still pretty helpful to be thinking about that. You can do lumbar punctures on a pregnant woman, and there is a recent report that if you do a single lumbar puncture, you can open up the venous sinuses just with a single lumbar puncture and bring about remission. Furosemide is a C drug, hydrochlorothiazide is a B drug. We avoid topiramate, even though we use topiramate a lot in IIH in a non-pregnant state because it helps with weight loss, it helps with lowering pressure. And the GLP-1 agonists are not used in pregnancy. And so that brings up, what about acetazolamide or Diamox, which has been the mainstay of therapy in the IIHTT, we use 2 to 3 grams. What about the use of that drug in pregnancy? So there are 2 major studies. This one was a case series of 12 patients with no evidence of teratogenicity. But the bigger study was done by Julie Falardo, where she went through 101 women, 158 pregnancies, and 50 pregnancies were before 13 weeks gestation with the use of acetazolamide. And what was interesting about this study is they actually had pediatricians examine the infants and they did not find any increase in birth defects. So in general, you can use acetazolamide in pregnancy because that does help with reduction of the intracranial pressure. So if vision is threatened, what are you going to do? Well, in our center, we've been taking to doing lumbar drains. This can temporize the situation. Sometimes it can get rid of it. I don't know if you do that here to help temporize visual loss, but we've got a protocol now for that. Optic nerve sheath fenestration is our procedure of choice because it helps with vision. It's not great for headache and it can be done safely in pregnancy. Shunts are really problematic. Imagine trying to put a ventricular or lumboperitoneal shunt in a gravid abdomen. It's a little bit more difficult. And then stenting, there's very few cases in the literature about stenting in pregnancy. So I can't give you any data on that because there isn't any. What about future health though? And I think this is where it is kind of important. Because obesity during pregnancy is an independent risk factor for cardiovascular morbidity and diabetes. If there are more pregnancy complications if you're just obese, There's also an increased risk of cancer and degenerative joint disease if you have obesity and pregnancy. And so it becomes really important for us to be thinking about these women over the broad spectrum. It's not just during the pregnancy, but thereafter. There are some very interesting studies that show that that obesity trend can go on to children, in part genetic probably, but in part environmental. And then offspring have a higher incidence of ADHD and even some neurodevelopmental delays. So I think this is a pretty important area that needs a lot more study. I want to mention migraine because I frequently get asked about this. Women who are pregnant who suddenly have their first migraine, okay? Remember, migraine also occurs in this age group, and aura occurs in about 20% of women with migraine. And sometimes that aura occurs in the first trimester. And the thing that you really want to do is make sure that there's no other cause of the aura, like preeclampsia, and that means get the blood pressure cuff out. Transient ischemic attack, very rare, or a seizure. Interestingly, if a woman has migraine with aura, they do have a higher risk of developing preeclampsia. So ask about aura if you've got a woman with pregnancy, and then check the blood pressure because you want to make sure that you don't have hypertension. There we go. All right, I'm going to switch gears to this woman. She's 31, gravid 3, para 2. She has a seizure, and then she says, I can't see. You know, preeclampsia or eclampsia is when you have a seizure, and it comes from a word of shining through, meaning can't see. So the vision is affected. Preeclampsia is 3 to 5% of pregnancies. Severe preeclampsia is only 1%, and eclampsia is even rarer, but visual complications do occur. So we make the diagnosis by the blood pressure, usually 160 over 110 or more. But in a normal pregnancy, blood pressure should actually be low. So it should be, 100 over 60. That's a normal blood pressure. So when you start seeing 140 even over 80, you have to be careful. You also see proteinuria, oliguria. You can have congestive heart failure, you can have pulmonary edema, and you can have HELLP syndrome with elevated liver function tests. And eclampsia is these above factors, but coma, seizure, or blindness is what defines eclampsia. And eclampsia is the feared one. There is a whole differential diagnosis that I'm not going to go into, and the obstetrician is the one that's going to probably help you with this, but you have to be thinking about other brain vascular disorders like RCVS, lupus, and venous sinus thrombosis. So just some neuro-ophthalmic findings during preeclampsia and eclampsia. When I was a fellow, I started this project. I continued it into my time in Utah, but we found that women had a lot of spots in their vision. Blurring spots, headache was, over half. Very few had weakness. Bring the Amsler grid with you to consult when you have somebody on the OB service. And for 2 reasons. One is Amsler grid defects were very common in these women. Color vision defects were also present, and there was some acuity changes. But the grid defects, if I can get this to come up, right? Often look like this, just kind of blobs within the retina, and then when you dilate them, you can see some choroidal changes. What was interesting to me is if they had a positive Amsler grid, they had a positive MRI scan, so you can almost predict that you're going to find findings of PRES by just doing an Amsler grid. And what kind of findings on the MRI scan, you get these curvy linear T2 signals a lot in the occipital lobe and also in the basal ganglia. And you can also you see what looks like PRES, this posterior reversible encephalopathy syndrome that can occur in a non-pregnant state and have visual symptoms as well. But in pregnancy, this preeclampsia, severe preeclampsia and eclampsia, that's what you're gonna see is a PRES-like picture. It's most often reversible. If there's a hemorrhage, it's not reversible. And then they have these very characteristic findings on MR with looking at the diffusion weighted imaging. On your left, you can see a diffusion weighted imaging that's real bright in the occipital lobe. And that's why our woman was not seeing. And if you look at the EDC, however, it shows increased signal as well. So this is telling us that we have vasogenic edema, not cytotoxic, and this woman is going to do fine, and she did. Now, there are findings that you can see in the eye as well. Everybody used to talk about retinal sheen, but as we know, that's just a very nice, robust internal limiting membrane. Vasospasm, I'll show you what that looks like. Serous retinal detachments are not rare. The one thing that you really see in a lot of these people are choroidal infarctions. These are small vessel changes in the RPE. You can see ischemic optic neuropathy. You can get increased intracranial pressure. And of course, you can have cerebral blindness from the findings on the MRI scan from this PRES-like syndrome. So on the far left, you can see that people can have vascular narrowing. You can get nerve fiber layer hemorrhages. You can see this nice serous retinal detachment. Those go away usually without any kind of treatment. You just watch it. But one of the findings really, this was a woman who had severe preeclampsia, visual changes. After her pregnancy, after she delivered, we did a fluorescein angiogram, and you could see these areas of choroidal infarction, and her vision recovered remarkably. This is a nice example of the serous retinal detachment. No treatment is required. These nerve fiber layer hemorrhages. And this was a woman that, you know, hay rate, I was at Iowa, so I had to be steeped in Sohan Hay-Ray's vascular theories of the retina, but he swore that vasospasm did not occur. So I did show him this case of where the artery definitely narrowed and then came back to normal after pregnancy. And this woman just had some blurring of vision and she recovered and her vision was normal thereafter. This woman was really interesting because she went home after the pregnancy, had a seizure, and woke up not seeing. And so she had postpartum eclampsia. And she has the typical PRES-like curvilinear T2 signals in the occipital lobe, and she did recover. But you can see what was interesting, she had a kind of a vasospasm that occurred in her vertebral arteries and posterior cerebral arteries. But this cerebral blindness is not rare, and the incidence may be actually higher than we think. People can have no light perception or bare light perception, but the key for the resident, when you go and see somebody, look at the pupils. Because if the pupils work, okay, it's gonna be in the brain. It's not gonna be, you know, the optic nerve or the retinal artery or anything like that. So if the pupils are doing great, it's probably in the brain. The OKN can be absent in these cases. It usually resolves completely. And it happens because there's a differential innervation of the blood vessels between the posterior circulation and the middle cerebral circulation. I don't know how many of you carry the cookie theft picture in your bag of tricks when you go to the consult, but we use that because you can see simultaneous agnosia in these individuals with eclampsia. You know, what happens, this picture, of course, is very complicated. So the person who has simultaneous agnosia can't see the whole picture, will describe, oh, I see somebody drying dishes. Oh, I see a cookie jar. I see a boy on a stool, but they can't get the whole picture all together. They can have visual field defects, and you can pick that up at bedside. Alexia can occur too. There are rare cases of permanent blindness, a couple cases of lateral geniculate infarctions, but this fortunately is completely rare. But carry so Amsler grid, cookie theft picture, especially if somebody's had a seizure and can't see. Then treatment for preeclampsia and severe preeclampsia is magnesium and delivery. But magnesium by itself has some neuro-ophthalmic findings that you can actually see as well. The convergence and accommodation becomes weak. So they say they can't see. Sometimes they can even have double vision. That handy dandy Amsler grid, you bring it and you go, is this the eclampsia or is this the magnesium? Well, and somebody that it's just magnesium, they're not going to have any Amsler grid defects. But so this was a patient we had who was on magnesium, and you can see that she's got a little bit of convergence insufficiency, bilateral ptosis, and then the magnesium went off and she was completely back to normal. So just be aware of that complication. Now, put preeclampsia and eclampsia on your list of health problems that you want to ask about in your history, because if a woman has this, it does portend chronic disease, especially hypertension and future cardiovascular risk factors. So it is really an important thing. And if you're aware that you are at risk for that, you're going to be paying attention to your blood pressure. You're going to have that treated a little bit earlier than if you're not aware. So we, even in ophthalmology, we are doctors too. So we can help people just recognize that there could be a risk down the line of future problems. I want to mention cranial neuropathies because this is not rare. Facial nerve neuropathies can occur, sixth nerve neuropathies can occur, fourth nerve, and it's felt to be related to that interstitial fluid. Remember, I told you that you have this huge amount of interstitial fluid in just normal pregnancy. You don't really have to treat this. Usually it gets better all by itself. But pregnancy is a big risk factor for a cranial neuropathy. Most of these are in the third trimester. You can just reassure the person that it will get better. Some people say steroid use is important, but most of the time we just let people improve on their own. Oops. I do want to mention postpartum complications with epidural analgesia. One problem is if the person gets a high block, you can get a Horner syndrome. So a transient Horner syndrome can occur postpartum if they've had a high block. Rarely other cranial neuropathies like trigeminal nerve. I do want to bring this case to your attention. This is a 23-year-old woman, and she came to me with kind of a low pressure headache. She did have an epidural 3 months before, delivered a healthy baby. But she came in with diplopia, and she had a 20 diopter comitant esotropia, and we did this MRI scan. And as you can see, she's got low-lying tonsils. See how the tonsils low? And then look at this pituitary is kind of almost convex, almost to her chiasm. Her pons is flattened. And these are really typical findings of intracranial hypotension or a CSF leak. So we did a blood patch and she came back, and you can see now her pituitary has a more normal configuration. She's got the belly of the pons now is normal and her tonsils have moved up. So double vision after pregnancy, ask about epidurals because sometimes they become spinals. And you can have a CSF. It's not common, but it does occur, and just a blood patch usually is all you need to do. So with an eye to future health, the first lesson for today is make the correct diagnosis. Use the test you need to make the diagnosis. Consider pregnancy-related conditions like eclampsia, severe preeclampsia. Think about hypercoagulable state in pregnancy. Know what these are. And I would add pregnancy complications to your history list because you can say, did you know you have a higher risk of X, Y, or Z, especially hypertension in later life. And then we're all kind of prenatal doctors. So we see young women who come into our clinics and we have to be aware of what factors they may be up against. And so just remember that all women of childbearing age we're all prenatal doctors. And the bottom line is what's best for the mother is usually best for the baby. And if you just keep that in mind, I use that mantra all the time, especially when my heart rate is going like this. I'm going, okay, I can take care of that mother and she's going to take care of the baby. I do want to tell you how many of you know about Novel Neuro-Ophthalmic Virtual Education Library? I hope everybody knows about this. We have lots of resources. There are interesting cases of neuro-ophthalmic changes in pregnancy on that website. And I also wanted to bring to you the Moran Corps, Clinical Ophthalmology Resources and Education, especially for residents. We filtered it by specialty in the BCSC series for ophthalmology. And in neuro-ophthalmology, we have other lectures on pregnancy and also just neuro-ophthalmic topics that are interesting. And lots of surgical videos in there, et cetera. And with that, I'm going to stop and thank you all for having me here.
Well, thank you. That was excellent. I think that's one of the scariest topics for ophthalmologists is, when that young woman with pregnancy comes in with a neuro-ophthalmic disorder and you can't find the neuro-ophthalmologist fast enough. So first of all, thank you for the summary. I do have a question for you. So we covered a variety of different topics there. So the answer will differ based on the unique pathology of each woman. But how do you counsel women who've had a neuro-ophthalmic complication in pregnancy about the risk in future pregnancies?
So it depends on which one. Let's say it's they have idiopathic intracranial hypertension. Let's take that one because that's so common. This one, when they're done being pregnant, I say, let's get together and talk because we know if we can keep the weight down, we can reduce recurrence. Okay, so really working on weight reduction, and maybe that's the time when they're not pregnant, put them on a GLP-1 agonist, which has been found to be very good for weight loss and getting them to lose that weight so that they don't gain weight. If they've had preeclampsia in a previous pregnancy, I follow their blood pressure if they're going to see me. We don't often take blood pressures in the eye clinic, but I think women of childbearing age, and especially if they're pregnant, I would get a blood pressure. And if they've had preeclampsia and they're doing pregnancy again, I would check that blood pressure. If they've had a stroke, it really depends on what the cause of the stroke was. If it was something that needs to be treated, I work with the neurovascular people about whether they need to be on any kind of heparinoid in the future pregnancy. So it really depends on what the problem was. If they had a cranial neuropathy, that interstitial fluid, you can't do too much about it because that's part of what happens in pregnancy. But you can reassure them that it probably will get better and probably won't recur in future pregnancy. So it really depends on what the problem is. But the one I really go after is the IIH because that is so common because it comes back when people have weight gain.
Thank you. Alan?
Yeah, I just want to say that was a fabulous talk. A lot of new information presented very clearly. One question I have that's related. I think many of us non-obstetricians want to prescribe certain medications, topical steroids, topical antibiotics. How can we find out? There used to be a mother risk at Sick Children's Hospital that we could call up and see about the safety of the medication for mom if she was pregnant or if she was breastfeeding. Is there some sort of a reference you could point us in the direction?
There are some places. We had a pregnancy risk line in Utah for people to call up. We have a pharmacy. I don't know about you, but our pharmacy is really good about drug information and you can get it really quickly. Most of these drugs have kind of an FDA clearance list of A, B, C, D, and X. Most of them do. With topical drugs, you can do punctal occlusions and use these drops that you need to use in pregnancy pretty easily. I just would occlude the puncta so you don't have any systemic absorption with it. Most of those are going to be fine. But I like the drug information line because it gives you the best information. There is Briggs Drugs in Pregnancy. I don't know if you've seen that book. It's like this thick. But it changes so frequently. And then there are all these new medications that come out. It's hard to keep track of them all. I mean, some of these, I have no idea. I have to call my pharmacy or drug information to get information on them.
You know, from an ocular surface perspective, punctal occlusion is very helpful. The other thing that's very helpful is just keeping the eyes closed because that prevents the pump forcing the drops into the nasolacrimal system. So I do a combination of that, but still I'm always weary about which drops are safe to use during pregnancy and lactation.
Yeah.
But thank you for the advice.
And all you corny people out there, help us figure out what to do about this dry eye in pregnancy. I don't know. I had to quit wearing my contact lenses. I never wore them since. I mean, it's just, I have to say it's a real deal.
You know, there are some very good new products that we take from the patient's own blood, like autologous serum tears and platelet-rich plasma, which are very effective and go a sort of a quantum step above the regular over-the-counter non-preserved tears. I'm sure you want to stay away from cyclosporin and lifitegrast. So I guess taking the patient's own blood is really very little risk. And that, in my experience, has been very helpful in patients with an aqueous tear deficiency.
Good. And I did see Edsel A had a question, but it went by me so fast I couldn't see it come up fast enough.
You asked if sleep apnea test.
Sleep apnea with IIH. Well, as you know, there's a higher risk of sleep apnea in patients who have raised intracranial pressure. So I don't send everybody for a sleep study, but boy, if they, I use a Berlin questionnaire or one of the other sleep questionnaires for sleep apnea. And if it's positive, I might send them for sleep testing.
Well, on the topic of IAH, there's one more from Dr. Sharma. He thanks you for a great presentation and asks, how do you approach patients with well-controlled papilledema, a severe headache burden? And this is with respect to IAH.
Yeah, I don't know. Are your clinics overrun with rule out papilledema? We've got, it's just like an epidemic of anomalous nerves coming into neuro-ophthalmology. And then some of them have headache, which makes it even more complicated. So we've been, if they're cupless discs, and we get OCTs, which I think they're really helpful in helping us sort out these anomalous nerves versus real papilledema. And then sometimes when you really can't tell, you might have to do a lumbar puncture and find out. And the MR scan may give you some clues like dilated nerve sheaths, empty cella, and narrowed venous sinuses.
When it comes to real dilemma, we do gradient pressure.
Gradient pressures on your venous sinuses, yeah. And I know that stenting is becoming more and more popular, and venous sinus imaging is becoming very popular in our place as well as across the country.
Okay,
But
we've
in
got
pregnancy, we
one
don't have any information.
we've got time for one last question. We'll go to Dr. Al-Difrawi for that one.
It was an excellent talk. Thank you very much. You presented that patient with cerebral venous thrombosis. Will you anticoagulate them in the same fashion as you would if they weren't pregnant, or will you do
Yes.
things differently?
No, you would, but you're going to use a heparinoid and you're not gonna put them on Coumadin. Because the Coumadin can cause mid-facial abnormalities, and necrosis for the face in babies, so we don't use Coumadin or warfarin. We would stay with heparin. And now we've got some newer heparinoid type treatments. And then I work with the neurovascular team because they're the ones that are up on all the newer anticoagulants and the safety in pregnancy.
Well, excellent. I think those were great rounds, a great way to start our academic year. So I do appreciate you making the effort to come out here. And we're very fortunate that Dr. Digre is going to stick around and do the resident teaching this morning. I think we're very fortunate to have such expertise visiting us in Toronto. So thank you for that. And Dr. Sundram, thank you for organizing these rounds. I'll give you the last word.
I have one small comment to make. Amanda said, if you see a pregnant patient, to find a neuro-ophthalmologist is kind of hard. For a neuro-ophthalmologist to get a high-risk pregnancy, obstetrician is kind of hard. You're kind of lucky that way. So someone.
I had instantaneous consultation. Yeah.
Right. Thank you, Dr. Digre.
Thank you.
Thank you all.
All right, everyone, have a good weekend. We'll see you next week for grand rounds.
Yes,
Thank you.
yes, of course. Well,